All right, so we'll go ahead and get started because several folks have flights that they have to catch at 4. So we're going to do a little bit of a speedier run through. And also we are going to move all our Hall of Famers up so that they can give their talks. We previously tried to intersperse things with other things, but we'll just have all our Hall of Famers just go ahead. So without further ado, I have the privilege and honor of introducing Dr. Morgenstern, who is Milton and Caroline Keverson Research Professor in Neurology, Professor of Neurology, Epidemiology, Emergency Medicine, and Neurosurgery at the University of Michigan, both the medical school and the School of Public Health. Louis chaired the NINDS Advisory Panel on Health Disparities. I was privileged to be a member, and his co-chair actually was Barbara Vickery. I remember that. He was, of course, also chair of ISC. I was also privileged to be a category chair for community and risk factors back then. So I learned a lot from Louis back then. And of course, Louis also won the Feinberg Award for Excellence in Clinical Stroke in 2015, and is also a Javits Neuroscience Investigator, which is a high honor indeed. Louis's contributions have been phenomenal. The first time I interacted with Louis, he probably doesn't remember, this was in the late 90s. You came to UC Irvine. I think they were trying to recruit you. And so you gave a talk, then it was phenomenal. And it was, I think, the beginnings of BASIC. And I was blown away because, again, I already started having interest in disparities and everything. And so, unfortunately, we weren't able to recruit you to UC Irvine back then. But it was great to hear about your work and then to see, of course, it all evolve into the BASIC studies, which you've been the visionary and creator of, and is the only US population-based stroke surveillance project focused on Mexican Americans, and the only one which has received NIH funding continuously since 1999, which is phenomenal. And of course, over 150 peer-reviewed publications have emanated from that. Louis has also contributed to shedding more light on how we view the differences in terms of cognition between Mexican Americans and non-Hispanic whites. And also, if that wasn't enough, has also pioneered studies in stroke behavioral interventions and community engagement, including the NIH-funded KID study, which was the first stroke intervention to target children. And also it improved middle school children's behavioral intent to call 911. So without further ado, Lucy is going to talk about the importance of health equity research for all populations. So I think this is a very, very timely presentation. Thanks, Louis. Did I make this small? See. Sorry. It's really, he did the same thing to me. Let's see here. Okay. Like, okay, here we go. Let's go back here. Yes. Thank you. Great.
Okay, thank you so much. I'm so privileged and honored and humbled to share the stage here with so many other great honorees today, and so happy that I've been chosen for this award. Thank you again so much. So I want to say that it's always been my dream to be a member of the Hall of Fame, although it was a different Hall of Fame, I must admit. So I was an avid New York Mets baseball fan growing up in New York, and really wanted to have a career playing third base for the New York Mets and be elected to the Hall of Fame. This actually is, the SEQUINS Hall of Fame is actually much more impressive, so I'm okay with that. So the picture that I've overlapped my face on here is a picture of Lenny Randle, who was the third baseman for the New York Mets during my pivotal development years when the Mets were in last place, and he was the only person that went to the All-Star game, batted over 300. Mr. Randle unfortunately passed away last year, but was described by Sports Illustrated as the most interesting man in baseball. He was a scholar, fluent in 4 different languages, and he did some bad things. He started a couple of brawls. He also has, there's a great video that you should definitely Google this evening. He's playing third base, not for the Mets, it was for an American League team. And there was a little squib hit down the third base line. He charged, but realized he couldn't pick up the ball and throw the batter out. So he got down on his hands and knees and literally blew the ball into foul territory. And all the umpires got together to try to figure out what to do because he was much smarter than all the umpires and was in that situation. So I have an autograph from Lenny Randall downstairs in our basement, along with all the other baseball cards that someday my wife and I will sell, which will finance our retirement. And in that, it's a picture just like this, and he signs it, to my friend Louis Lenny Randall. Now, growing up, when I grew up in New York, I grew up in a very diverse part of New York City. I went to a very diverse school. And my parents didn't say, well, why did you choose a Black American as your hero? That just was not part of our culture. Our culture was one of great diversity and just kind of normal relationships. When I was 15, my parents decided to move us out of New York, and we moved to San Diego. We lived in a very residentially segregated neighborhood. I went to a very segregated school. And at that point, I started understanding how the world really is very different than my upbringing. And so as I went through college and medical school, it was really just kind of a natural thing for me to decide to work in the area of health equity and health disparities. I never thought all these decades later that I would have to justify that. The one thing that I thought was perfectly reasonable was that I was doing what was the morally correct thing. I was giving up lots of money that I could have gotten in private practice or by working with industry. I was doing what I thought was very important. But recently, there's been criticisms both from the left and the right about health equity research. And I think that, for or better or worse, despite that reasons we may not like these comments, we have to reckon with them. And if we're going to move things forward, we have to understand them and understand where they're coming from. So from the left, there is this article that I think typifies what some people have said: health equity tourists, how white scholars are colonizing research on health disparities. And I don't think that this is about people like me that have been doing this for 30 years. I do think that there are a number of people who saw recently that there was funding attached to doing health disparities research. And they had absolutely no interest in it, but they thought it was a way to secure money. I do think that this is a very important comment, and one that we have to realize. When we work in communities, we actually have to work with those communities and not have the paternalistic approach that many health equity researchers have. And so we have really tried in the community that I work with in South Texas to involve members of the community, take direction from them and participation. It's hard sometimes when community members have their own lives and their own agendas, and building research infrastructure is not necessarily what they want, right? So sometimes funding agencies say, build research infrastructure, but the community doesn't want that. They're happy to have you there. They want a say in what happens. And again, we need to think about it. In terms of the right-wing criticisms, I think all of us are just absolutely beleaguered by this, and I dream about this at night now. I think it's constantly in our view. While we may disagree with all points that have been raised, we have to live with it, and we have to find a way to overcome it and move on with the important agendas and missions that we share. So to do that, I hope to suggest some things that you may find helpful to put in your grants and other things to try to show why health equity research is important for everybody in the United States and why it should continue. So one is, the most important factor: morals suggest that one group should not suffer more than others. Monitoring trends in population health facilitates public health planning and priority setting. Surveillance allows discovery of new trends that need intervention in every population that is studied. And I'm going to show you some evidence of that. And looking within specific populations, understanding resilience mechanisms may transcend race, ethnicity, and be important to all populations. So this is the lovely community that I do most of my work in South Texas. Corpus Christi, Texas is an urban population in Nueces County, Texas on the Gulf Coast. It is the Texas Gulf Coast, and it is the Gulf of Mexico. And as you can see, the prevailing industry in the back here are smokestacks. It's a very big oil and chemical industry. There is agriculture here as well. There's also a little bit of tourism. But the socioeconomic status differences of the predominant population in this community, Mexican Americans, reflect the broader population of Hispanic Latinx in the United States. I should mention that routes of immigration do not go through Corpus Christi. For some reason, almost all the Mexican Americans in Corpus Christi are US citizens, second, third, fourth generation. The routes of immigration kind of go from the valley up to San Antonio or Houston, but not to Corpus Christi. So the facts about the Hispanic Latinx community are that it is the largest minority population. In 2020, there were 62 million Hispanic Latinx individuals, comprising 18.7%, a growth of 46 million people since the year 2000. Mexican Americans are the largest subgroup. They are projected, the Hispanic Latinx population is projected to comprise 1/3 of the US population by 2060. This population is aging rapidly. And so diseases like the ones that I study as model diseases, stroke and cognitive impairment, are much more likely to be prevalent in this community, and it's expensive to care for this population. So another important thing, if you're not into the moral aspects of why to look at certain populations, this is a very expensive disease and an expensive population for our country. So the number of participants in our work, we count every single stroke patient and have counted every single stroke patient since January 1st of 2000 without fail. These numbers are about a year old. So over 80,000 participants have been screened. Remember, the population in the community is only 360,000. And we have found over 15,000 stroke events at this time. This gives me pause to mention that we are incredibly grateful for the participants in the study, for these over 15,000 people who have participated in our work, embraced it as their own. And it's a really wonderful opportunity to work with them. So I want to tell you a little bit about some of the trend data that we found. And so this work published by my main partner in collaboration, Linda Elizabeth, temporal trends in ischemic stroke rates by ethnicity, which was published in Neurology a couple of years ago. And what you can see by looking at this young age group, this is relative risk. And it shows that when we first started the project in 2000, there was almost a doubling of the risk of stroke in Mexican Americans compared to non-Hispanic white. But at the end of the 2000 teens, we find the opposite, actually. Non-Hispanic whites in younger ages have a higher risk of stroke in younger ages than the Mexican Americans. Similar trend found in the middle age group, 60 to 74, and kind of a complicated relationship in those over the age of 75. Now, the younger population, the reflection of why Mexican Americans relatively are so much better than non-Hispanic whites over time is because the Mexican Americans have had less stroke. But the other thing we found is that the non-Hispanic whites have actually had more stroke, okay? So we did not set up this study to look at non-Hispanic white health, but one thing that we have found is that the non-Hispanic white population is not healthy, particularly in middle age. This has been shown in other studies and was originally attributed to the opiate epidemic, although we don't find any association to opiates with this stroke risk. So again, another reason why doing disparities research is not only the target population that you're studying, but the comparison population. So in this editorial that accompanied this paper that Tracy Madsen wrote, in addition to clinical implications, the findings presented in this study support the need for continued stroke surveillance studies to monitor trends over time and to help guide prevention approaches for various demographic subgroups. It will be critical to evaluate whether similar improvements have occurred in stroke disparities among Black individuals, another underrepresented group at elevated risk for disproportionate stroke risk. So what about outcome? So another Linda paper from last year shows kind of, again, somewhat complicated but interesting findings. And looking here at neurologic outcome using the NIH stroke scale, you can see that once again, the Mexican Americans had a much worse neurologic outcome from stroke when we started the study early on, and then over time that has absolutely completely disappeared. So virtually all the disparities that we initially saw when we started this study have gone away. So I want to show some unpublished data with you. I know it's always great to see some data before it's published. We're still working on this, so we're just kind of finalizing this manuscript for submission. The first author is Ahmad Hijazi, a fourth-year medical student who will graduate in 4 days and become a neurologist. He's going to do a neurology residency. And Amanda Malangaggio, who graduated from our undergraduate program and is applying to medical school now. And so this project looked at ethnic differences in post-acute stroke rehabilitation. So what we had previously shown in a study was that Mexican Americans had worse stroke outcome. And we thought that that was in part due to the fact that they were getting less aggressive acute stroke, less aggressive post-stroke rehabilitation. And so if you look at this line here, you can see that the highest level of rehabilitation, the most intense, is an inpatient rehab facility. That happens in 35.7% of our Mexican American patients in this community and 43% of the non-Hispanic whites. When we model this to try to figure it out, what we found was that this effect went away when we added socioeconomic status into the model. It went from a significant result to non-significant. Now, one of the interesting things about doing disparities research is that often reviewers ask us to model to try to figure out what are the effects. And when the effect goes away, they say, well, there's no disparity. That's not true, right? What we showed was that Mexican Americans are less likely to get intensive rehabilitation after stroke than non-Hispanic whites. In this particular circumstance, it seems that it's most likely that socioeconomic status has the most profound effect. And we know that there's a big intersection between socioeconomic status and race, ethnicity, and we need to really do a lot about both of those, about the socioeconomic status issues that are predominantly related to residential segregation and income inequalities. So the Black American community in Nueces County is very small. And so for many years, we've collected data on this very important population. Much of the work that studies stroke among Black Americans come from urban areas and from areas where the Black American population is closer to the population in the United States, 12% or so. In Corpus Christi, it's more like 2 or 3%. So we took many years to put together this data where we looked at stroke outcome compared with non-Hispanic whites. A lot of the data that we have on Black Americans and stroke have to do with acute stroke therapy and that type of outcome, mortality. We don't necessarily have survival data. And so what we showed in this very recent article was that outcome among Black Americans is worse in all circumstances, whether we look at neurologic, functional, or cognitive outcome. Mortality differences are similar, and we think that the main reason for that is the less likelihood of Black Americans in this community to get do not resuscitate orders. That long-term mortality is actually probably, if not very similar, actually higher in the Black American community. So I want to turn now to the idea about resilience and studying this within populations. And so one of my heroes is Herman Taylor, who is at Morehouse, who wrote this perspective and has been doing some research on Black resilience. And Professor Taylor, who is a cardiologist, and his group wrote that the health of African Americans has largely been described in terms of deficits, disease, and death. Little attention has been historically given to the fact that African Americans as a population show the sustained ability to survive an evolving array of social, economic, and environmental adversities that date back to more than a century before the founding of the US. While these inequities have indeed taken and continue to take a devastating toll, There is also wide heterogeneity in outcomes, suggesting the existence of substantial individual and collective resilience among African Americans. This perspective aims to stimulate discussion and research that explores resilience in a population in which overcoming and bouncing back from adversities, ranging from minor incidents to legally ordained chronic and horrific oppression, has been a requirement for survival. Rigorous scientific exploration of Black resilience may yield important insights into the phenomena of human resilience that transcend race. So again, I think this idea that if we understood what are the mechanisms of resilience within the Black and American population or within the Mexican American population, that might be beneficial for the non-Hispanic white population as well. Something good to put in your grants. So this work that another one of my key research partners, Aaron Saronic, and I did the OASIS project, Surrogate Decision Making, where we looked at the family members of people who had severe stroke and tried to look at their caregiving and the effect of the stroke on them. And you don't have to worry about the graph. The bottom words kind of sum it up. This is a study of 257 stroke patients and 320 surrogate decision makers who made decisions on life-sustaining treatment. Surrogates completed validated measures of quality of communication and shared decision-making. Contrary to our hypotheses, surrogates of Mexican-American patients tended to report better outcomes than non-Hispanic white surrogates. These results are encouraging for health equity and suggest lessons to be learned for all populations to improve health professional communication. In a similar work, Roshanak Metapana, working on our other cohort study looking at cognitive impairment in Corpus Christi, looked at caregiver health and found that increased burden is associated with worse caregiver mental and physical health. Mexican-American caregivers had stronger familism, resulting in better health. Findings can contribute to early identification, intervention, and coordination of services to improve caregivers. So in both of these studies, the Mexican-American populations actually fared better. So instead of us continuing to publish only data that says that that communities of color fare worse, it's time that we started publishing these data about the many positive determinants of health that we find. So I also want to briefly mention this work that an excellent postdoc, Chen, who got her PhD with Linda and me just a year ago, had worked on as well. So we've made this anecdotal observation over the years that it was much easier actually to recruit the Mexican American participants in the community than it was to recruit the non-Hispanic whites. So for years, everybody's been saying that communities of color have mistrust of the healthcare system, won't participate in research. And Lisa Newman, the famous surgeon from Cornell who lectures in both of the undergraduate classes that I teach, has said that the number one reason why Black Americans are disproportionately not involved in cancer clinical trials is that nobody asked them to participate, right? So if investigators have been told for a long time that persons of color are mistrustful and won't participate in your study, but you need to recruit at this level, there is a problem there, right? And I'm just not so sure it's true, right? I mean, there is a long history there. We need to acknowledge it, but we also need to not take for granted that there is this mistrust. And so what we found in this study, both in basic, and we published another study in basic cognitive, is that the Mexican Americans were actually much more likely to participate. In this case, actually, it was the most profound effect, more important than any of the other things that we look for in the model, 17% more likely to say, yes, I will participate in your research than the non-Hispanic whites. So we're not the only ones doing this work. There are other people who are involved in resilience work. I mentioned that Morehouse is a really important part of that. This was a study looking at Life Simple Sevens, the American Heart Association's key to trying to reduce risk of heart disease and stroke, and showing the tremendous association of different mechanisms of resilience shown over here and then summed this really, really strong association of doing the Life Simple Sevens with resilience mechanisms. So if we can teach people to be resilient, if we can help bolster their resilience, that might be very, very important for the preventative work that we're trying to do in heart disease and stroke. So problems with interventions to bolster resilience. Why not work on removing structural racism to avoid the trauma that builds resilience in the first place? Totally agree with that. Efforts to bolster resilience through psychological interventions are largely untested. We need more clinical trials in this space. As part of studying resilience, a focus should be on intra-race strategies rather than inter-race strategies. And again, something that I really think is kind of this positive determinants of health. So this is a model that we've adapted of resilience capacity that was developed by Linda Gallo from San Diego State University. Professor Gallo has worked on the study of Latinos for many years and has this research capacity idea that we get a certain amount of capacity in our bucket. Things happen in our lives and some spills out. We can add more in. So there's constantly stuff spilling out and we're adding it in. And these are the different things that kind of make up that bucket. Sociocultural factors, ethnicity, psychological factors, those types of things. And so the current cycle of basic years 26 through 32 is really dedicated to trying to figure out what are the things that can help us fill the bucket. What is the most important things based on this model? So what can everyone in healthcare do to improve equity? I think that, we all believe that promoting diversity is very important in all of our lives. Lisa Newman talks wonderfully about how diversity improves not only patient outcomes, but in business improves success and outcomes from business. It's just remarkable that this is not universally understood. Look at your own institution's data. I'm going to show you our data in a second. Be aware of your biases and obtain training in implicit bias. Now, I left that in there, although as many of you know, the research in this area suggested that implicit bias training has not been as effective as we'd like it to be. It's something that needs to be worked on. Engage with others by opening a dialogue to talk about health equity. I think all of us have feel that we're a little silenced by what's happened in this country. Now is the time we need to talk about it more rather than less. So this is just some quick data to show that we look all the time at our data. Door to needle time is a measure of what we're doing for stroke patients. We analyze it, and as you can see here, actually, our problem is in too long door to needle time in our white patients. And here is just somewhat of a complicated slide that I'll just abbreviate by saying that we're looking at quality metrics here, and we're looking at compliance with Joint Commission quality metrics. And essentially, on all the race ethnic groups, we're like at 100% in almost every patient. So again, I come back to this concept that these are societal problems, right? We're trying to deal with them in the health sphere, but the twin pillars of residential segregation and income inequalities continue to wreak havoc on our society. And I think that efforts to change this as individuals, as groups, as society, really are what's most likely to have the biggest effect on what will happen in the future. So I have the fortune of teaching 3 undergraduate classes at the University of Michigan as I make my slow transition to becoming a college professor. And one of the classes is called The History of Racism in the U.S. Healthcare System, which I've taught for the last 4 years. About a third of the way in this class, as we go through the devastating history from Reconstruction through the present, of how structural aspects in our healthcare system were designed and continue to cause terrible problems for members of our society to get adequate healthcare. But about a third of the way in the class, I pause and I say, so how many of you here are wondering why this Jewish boy from New York is teaching this class? And all the students just kind of look at me like, and then they all start raising their hands, right? And so, I use that as an opportunity for them to kind of, list who, and discuss who they are. What are the factors? Who are you, right? So I could probably come up with 120 different things. I've just listed 12, right? And so number 1 is most important. I would do anything for my family. But number 2 is I'm human. I'm just like everybody else, whether it's a homeless person or somebody who, is a billionaire person who lives in Gaza or wherever else. And that kind of allows me to do the things that I do. And I think it's really important that we don't tell people how they should rank things, right? That's not our job. People rank things how they should be. If their gender or their citizenship or their religion is number one, then we have to honor that and understand that. But I think it explains the frame of reference where people are coming from, right? If my family members lived in Gaza, I would feel very differently about the situation there. And I think that we need to understand that and have the empathy that it deserves. So I'm going to end by thanking my colleagues, principally Linda Elizabeth and Devin Brown at the University of Michigan, who I've had the privilege of working with for the last 20 years, and Darren Zoronic as well. Our project managers, Mindy, Nelda, and Aaron, and a host of collaborators that I've really enjoyed working with, some of which are listed here. And then my many mentors from high school through times on the faculty at Michigan. The picture there is a very old picture of my daughter with her godfather, Jim Grata, in Houston, standing in front of a Houston mobile stroke unit. I also want to recognize our NIH program officers who have really contributed tremendously to the direction that our grants have gone. So thank you.
Louis, for that fantastic talk. Questions, Dr. Sharif?
So thank you for that amazing talk. I also want to thank you for the impact you've had on me personally. Your very early mentorship of me when I was feeling very lost early in my career. So thank you for that. I do have two questions. So one, so when you think about the population in Corpus Christi, there are some things that are unique about that population, the environment, the makeup, but also basic being there. So do you think that the experience, what you've noticed in Corpus Christi, reflects the experience of Mexican Americans in the US? And then the second part of that question, the changes, the improvements that have been seen over time, do you think those are related to medical things, system things, social things, the presence of basic? What is accounting for those differences?
So first I'll say, I think my biggest gift in medicine is being a good talent scout. And Dr. Sharif, you're a good example of that. So recognizing talent and encouraging it is the important thing. So Corpus Christi is, okay, I'll tell you first what we say in the grants, and then I'll tell you a little bit more. So in our grants, we say that Corpus Christi is a microcosm of what the U.S. is going to become, right? Multicultural, very large population of Hispanic, Latinx population that are U.S. citizens, right? We had a grant that was also unscored that we tried to talk about bilingualism. And what we were interested in was that the Mexican Americans were going to learn Spanish because they've grown up in the United States. They don't know Spanish, right? So that, and the reviewers had a real hard time understanding that. So I think it is kind of where we're going. Does it reflect an immigrant population from Houston or San Diego or New York or something like that? Probably not, right? The other thing about working with Hispanic Latinx population and the criticism we get in every grant and every paper we submit is, you're talking about Mexican Americans. What about Caribbean Americans and everything else? Well, I mean, we can't do all that, right? We're not trying to speak for all the subpopulations of the overall Hispanic Latinx population. And we're trying to look at some commonalities. Do I think that it's improved medical attention? I think that the epidemiologic work that we and others have done have raised tremendous awareness. And I think the advantage of, health equity, health disparities work, not just pure intervention work, but just basic epidemiology and all the press that it gets and everybody knowing about it, is that people spend a lot more effort, doctors, nurses, health professionals, on these target populations, and people in the populations also know a lot about it. So, yeah.
Questions? Okay, Dr. Sankar, Dr. Littlejohn, Dr. Jola.
Hi, Dr. Morgenstern. This is great for me. So Richard's a big fan, and I've learned a lot from him as a stroke neurologist, and so I think I'm trying. Can you speak about the difference between addressing health disparities versus advancing health equity from your perspective, and how the language, whether it's nuanced or not, kind of what are the important components that we need to think about when talking about equity versus disparities?
Yeah, I think it's an excellent question and somewhat complicated, and I'd be interested to know what you and others in the audience think about it. I think words are important, and we should be careful about how we choose them. I think sometimes people kind of glom onto words because it seems to be the correct thing to do at the moment. To me, disparities are simply defined as differences in populations due to social factors that should be remedied, right? And health equity is the opportunity to correct those, disparities. So, that's kind of a simple type of definition. Right now, the question is, what words are we allowed to use and what are we not allowed to use? And does it make a difference? And part of me is like, they're just words. And then the other part of me is the words are important. So I wish I could give a better answer, but it's what keeps me up at night.
Thank you. Great talk. My name is Erica Littlejohn from Kentucky. So I study early life child abuse and neglect, including things like interparental violence and the impact of that early life maltreatment on late life cognitive impairment. And when we look at the literature with intimate partner violence and disclosure, we find that one of the strong motivators for participation is the idea that they might help someone else in the future. And so I was really curious about your Mexican American participation willingness data, and if you all are doing any follow-up qualitative studies to understand the motivation, because I think that'll have really important implications for community engagement with subpopulations.
Yeah, sounds like you're doing very important work, so thank you for that. So we have not done any follow-up work. I will say that people know us in the community. We've been around for 25 years. I mean, if you go to people's homes and ask them to participate in this study, they'll say, oh yeah, my neighbor, or my aunt, or somebody. So that helps. We give the opportunity for, our interviews and our discussions are available in Spanish and English, or although, as I previously said, almost everybody in the community speaks English. We haven't really done a lot, right? We haven't done a lot of the outreach stuff to the Hispanic Latinx community, right? We've just done outreach stuff to the community. So we haven't specifically targeted strategies. And that's, I think, the important message here, that we think that there is a sense of altruism within this population that doesn't need a lot of encouragement. And that if we approached it thinking that it was a problem to enroll them, right? I mean, that's what we're told all the time, right? That there's a problem enrolling communities of color. I just don't think that's true, right? I think that this population is actually much more altruistic and much more desirous of working with us than the non-Hispanic white population. We have meetings to try to figure out how to recruit the non-Hispanic whites, not how to recruit the Mexican Americans.
Thank you. I'm gonna kind of like forward a question that they asked me at ISC, and was, how do you choose a community to work on? So what, if you're a junior researcher and you're interested in working in community engagement, how do you pick your community?
So, so I'll just tell you how I did it. I just kind of lucked into it. When I was a stroke fellow at UT Houston, there was a group of cardiovascular researchers at the School of Public Health, and they had a project called the Corpus Christi Heart Project. And they were studying disparities in heart disease in this community. So I started working with them, wrote a couple of papers, and then we turned it around to do stroke. If I had to do it all over again, I would really want to work with the community. I mean, I think the CBPR, community-based participatory research, is the best way to do it, right? To really work with the community from the beginning, to work on a topic that the community wants, to have them work equally with you on every single part of the project, right? Whether it be writing the grants, establishing the funding, determining how the money is spent, how the data is going to be analyzed, writing the papers, every single part of it, a true partnership. That's the best way to go. That's not what we did when we started things. And as I mentioned, we've just hundreds of times we've reached out to many different parts of the community. There's a university in Corpus Christi, Texas A&M Corpus Christi, but they just don't have the research infrastructure to run something like this. And they don't really want to. They want to be part of it, but as a partner, they want us to run it. So, but yeah, I think the CBPR thing is the best way to go.
Hi, I'm Elise Enriquez. I work out of Seattle. I'm a child neurologist, and I do neuromuscular. So I work very closely with kids who have like Duchenne muscular dystrophy, spinal muscular atrophy. And when I say the kids, I'm really working very closely with the families. And I don't really have a question. It's more of a comment and a realization of my own biases. So when thinking of clinical trials and research and recruitment, I am guilty of thinking Spanish-speaking community does not want to enroll in these trials. Not that I don't offer it. Actually, I go out of my way. I make sure materials are translated into Spanish to make sure that these kids are getting enrolled in trials. But I have really experienced the hesitancy from families where they feel like we're poisoning their children, or that we're experimenting with their children, which in a way we are experimenting, right? And that has been really, really difficult for me to respond to. But what I came out from this talk was that maybe I need to be looking at the positive things from this community and try to rephrase it differently. And it is true that this community is very altruistic. It is also true that family is so important. So how can we, and I'm just kind of posing this question, not expecting an answer, but how can we use that information to phrase it differently when we're asking families, are you interested in participating in a trial? It was really just more of a comment of what my experience has been, understanding that also the community is very different. These are mostly first-generation immigrants that are working in the farming industry.
No, I thank you for the comment. I think it's very important. And I think treating people with respect is fundamentally important. And I think that, this notion of unconscious bias is really important. I think we approach people differently based on what they look like, what our preconceived notions are. One of the most pivotal moments for me occurred very early in my career. We were doing the NINDS TPA trial, and I was on call one night. It was the middle of the summer in Houston, and I got a call to Southwest Memorial. I drove there. It was like 1 o'clock in the morning. I had a t-shirt on and a pair of jeans. My hair was flying everywhere, and I was like, 27 years old or something like that. And there was a Black American woman who was having a large stroke, and her husband was there. And I started telling him about how we needed to make this decision because I needed to enroll her in under 90 minutes in this trial, right? And he says, looking at me like, what is going on here? And, I stopped and I treated him with respect and tried to explain it. And he said, you need to talk to her doctor. So he got the doctor on the phone and I spoke to him, and they agreed to be in the trial. She was randomized. I have no idea what she got. But 3 months later, when I saw them in clinic to do the outcome, and I was wearing my white coat and had my tie and my hair was combed, I said to him, tell me honestly, what you were thinking when you saw me. And he just let me have it, right? He just said, you know, you were just some young kid and, you know, you're white. And he goes, I just thought you were going to experiment on my wife. And it was just a really, really eye-opening experience. And I was so thankful that he was willing to share that with me. And, you know, then he laughed and said, you know, how happy he was that they were part of it and understood it and everything. But yeah, I think we need more experiences, you know, like that of interacting with people and seeing it from their side, having that empathy.
So